Bueno, es el momento nuevamente de presentar un bloque conformado por 4 conferencias, iniciando con el doctor Michael Struck, después el doctor David C. a continuación y finalmente el doctor Struck. Please, Michael.
Thank you, Ricardo. Muchas gracias. So now we move over to real vestibular disorders in a very systematic way. And before I move on, I would like to thank Ricardo for translating the slides into Spanish. I think he did a great job. Thank you very much. And on this occasion, I would like also to mention that Ricardo translated our Vertigo book into Spanish. We are just looking for an appropriate publisher and some opportunities to sell a huge bulk of this book. Anyway, so now we talk on peripheral vestibular disorders. And what you see here is one of my most important slides because it again connects anatomy, physiology on the one side, pathophysiology, and signs and symptoms. And this is very important for your understanding because you can classify all peripheral vestibular disorders just into 3 different types. Very simple, almost trivial. So there are patients who have a bilateral vestibulopathy. These are the patients who do not have any symptoms while sitting or lying down, because then you don't need your vestibular system. But when they get up, they feel dizzy, and the symptoms typically become worse in darkness and on uneven ground. And that's easy to explain because our balance gets information and needs information from 3 channels: vestibular organs, eyes, and proprioceptive system. And if you imagine that your vestibular system is not working properly and you close your eyes, then you really feel dizzy and have a high risk to fall. So this is bilateral vestibulopathy. It's unfortunately often not diagnosed. Another subtype is an acute unilateral vestibular failure, classically in vestibular neuritis. These patients have an acute onset of rotatory vertigo lasting many days up to a few weeks. This can also be caused by a brainstem infarction, by the way, which affects the vestibular nuclei or the vestibular nerve within the brainstem. And the symptoms are the same. So, acute onset. These patients with vestibular neuritis, they also have oscillopsia. But in these patients, oscillopsia occurs spontaneously, whereas, as mentioned before, in patients with a bilateral vestibulopathy, oscillopsia occurs only during movements due to the deficit of the vestibular ocular reflex. And the third and most frequent type is caused by a pathological stimulation or inhibition of the peripheral vestibular system. And that's the price we have to pay for such a sensitive system. So small differences in the action potential frequency between the left and the right labyrinth, 5 Hz, induce vertigo in night-seconds. And these are the most frequent types. So what can you classify here? Which vestibular disorder? Any suggestions? And yes? What else? Vestibular paroxysmia, vestibular migraine, BPPV, perilymph fistula. So these are the frequent ones. They're all characterized by attacks of vertigo. And here you also see an overview of the different types of peripheral vestibular disorders, and these are the topics we are now going to deal with. So We already talked about superior canal dehiscence syndrome, so I'm not talking about that. I'm going to talk a little bit about BPPV and its mechanism. Then we talk about Meniere's disease. We are going to talk about acute vestibular neuritis, vestibular paroxysmia, and bilateral vestibulopathy. And this slide gives you an overview of the different types of vestibular disease. And here again, that you see how frequent vestibular disorders are. We saw that before: BPPV, Meniere, vestibular neuritis, bilateral vestibulopathy, vestibular paroxysmia, and perilympus. So they cover more than 60% of all your patients. So now listen to the patient history and try to make the diagnosis on the basis of the patient history. I hope the sound is working.
You come to us because of dizziness. How long have you had it?
For about 1 year.
Is it always present or only in certain situations?
It's always present. For instance, when I run or walk, when I climb up a mountain, when I move, and...
Do you feel it while you're sitting or lying?
I'm not dizzy when I'm sitting or lying. Then I have no symptoms. What is really strange is that when I climb up a mountain, I get dizzy, but when I go down, I'm not. That's very odd.
When you're moving, can you recognize objects or persons well, or are things less clear than you're used to?
Well, I can see things and objects and persons quite well, only when I'm walking in the street and I see some sign with writing on it, then it's blurry.
If you stop walking, can you read it then?
Yes. When I stop, then it takes a little while until everything calms down, and then I can read it again.
So, again, if you listen to a patient, try to answer the 4 cardinal questions. What type of vertigo or dizziness is this patient complaining of? Postural imbalance, dizziness. When do the symptoms occur? While walking, having no symptoms, during sitting and lying down. Accompanying symptoms? Oscillopsia, but nothing else. So just on the patient history, what do you diagnose? Bilateral vestibulopathy. And an elegant test with its limitations, as mentioned before, is the head impulse test. So in this patient, it was easy. We do quick turns, and if patients have a significant deficit, you can diagnose it with the head impulse test. So that's easy to diagnose. Do it very quickly, but do it too slowly. And there's another test which is helpful, and this is the Romberg with the eyes open and the eyes closed. With the eyes closed, in the tandem Romberg, the patients have an increased sway with a risk to fall. So if you have these findings, you can be quite sure about the diagnosis. And as I mentioned before, there's a classification committee of the Bharani Society, about 12 people, and we classify or reclassify the different vestibular disorders. And this is the classification committee on bilateral vestibulopathy. You see all the different continents are represented, which is a requirement for that. And these are the currently recommended diagnostic criteria for bilateral vestibulopathy. You're already familiar with the patient history, with postural imbalance and dizziness, which occurs during movement. It becomes worse in certain situations, and the patients often, but not always, have movement-induced oscillopsia. To make a precise diagnosis, we also have to quantify deficits. And there's now an agreement, if you do the video hit, that the VRR gain should be below 0.7. There's an agreement on that. And if you do a caloric irrigation, which is still a very important test, the sum of the peak slow phase velocities of the nystagmus on the right and the left side should be less than 10 degrees. So that's the agreement. And this is a standard sentence, not better accounted for by any other vestibular disorder. If you know the diagnosis, you can add the etiology, for instance, gentamicin or bilateral Meniere's disease. Complementary tests are the Romberg test, dynamic visual acuities, and vestibular evoked myogenic potential. And we pointed out that these are just complementary tests because the majority of doctors do not have vestibular evoked myogenic potentials. In other words, you can make the diagnosis everywhere. You don't need to have the VEM. What about the etiology? A few years ago, we published this series on 255 patients with bilateral vestibulopathy. And it's important to point out that in 3 out of 4 patients, there is no definite cause. So if you don't find anything, you should not be frustrated. This is reality. Identifiable causes were ototoxic antibiotics, gentamicin, bilateral Meniere's disease, which you can nowadays prevent, and after meningitis, tuberculous meningitis, and encephalitis, and also associated with the cereballitis. Everything else was rare. What already came out in this study in 2007 was an association with cerebellar disease. So, what about the etiology? To summarize that, ototoxic substances, bilateral Meniere's disease, infectious or autoimmunological disorders, and I'll later show a video on that, cerebellar ataxia, neuropathy, vestibular areflexia syndrome, and new neurodegenerative disease. What really counts for the patient is the treatment. And I think a very important step is to explain the patient why he or she feels dizzy. So take your time to talk about the vestibular system. Most patients understand that pretty well, why we need it, and what happens if your vestibular system is not working properly. And tell the patient you have a peripheral problem only and nothing else. And most often it's not getting worse. So that's a great relief for the patients, if they exactly know what's wrong with them. Similar with your car. If there's something wrong with your car, and you know what it is, it doesn't bother you as much. And now imagine a patient with permanent dizziness. Not knowing what's wrong, you give him or her the information, that's a great relief. Prevention is very important for ototoxic substances, so be very restrictive with the use of gentamicin. Or, an alternative good treatment is therapy of the underlying cause, for instance, as in Meniere's disease, as you will see later. And all patients require vestibular rehabilitation, which in Mexico has a very high level. I realized that during several talks. So you have here a National Institute for Rehabilitation. So you do that here at a very high level, similar to the United States, and I appreciate that very much. It's much better than in Germany, by the way. Good. Okay, next patient. Listen to the patient history and try to make the diagnosis in this young, otherwise healthy man.
What complaint has brought you to us today?
For dizziness, which I've had since early yesterday, ever since I got up.
What type of dizziness is it?
At first it was a spinning sensation which has abated a bit. It was simultaneously combined with strong nausea.
Did you have any other complaints?
No, not until then.
What happened when you tried to focus on one point?
Then the image began to wander and again to wander. In other words, I was not able to focus on one point.
Besides dizziness, did you have any other complaints like seeing double, problem swallowing, difficulty speaking, paralysis or numb feeling around the mouth?
No, so far not.
And are you still experiencing dizziness?
I still feel dizzy. It seems to have abated somewhat at the moment.
So, once again, the 4 cardinal questions. What type of symptoms? Spinning around. The time course. He got up with these problems and they lasted at least 2 days. Accompanying symptoms. Nausea, oscillopsia. And now the key questions. You have to ask every patient for possible accompanying symptoms. So, double vision, tingling around the mouth, weakness, problems with swallowing, weakness of the arms or the legs, impaired sensation on one side of the body. Again, patients are most often not aware of that. You have to specifically ask them, Otherwise, you will miss the brainstem infarct. What would you diagnose on the basis of the patient history? BPPV? No. What else? Vestibular neuritis. Okay. Now look at the patient. We see a nystagmus. A little bit when he's fixating a near target, then you see it a little bit. And when he's looking into the direction of the quick face, according to Alexander's law, but he does not have a gaze-evoked nystagmus in the opposite direction. So during convergence, he cannot suppress the nystagmus as well as he's able to do when he's looking straight ahead. And now here are the glasses. Now you clearly see it. Okay? So the glasses prevent visual fixation suppression of the nystagmus. And then you clearly see the nystagmus, which is beating to the right and has a horizontal torsional component, which is typical. And now the head impulse test, clearly pathological. Okay? So no central signs, pathological head impulse test, and a nystagmus that can be suppressed by visual fixation. All this supports the diagnosis of acute vestibular neuritis. To summarize the clinical findings: horizontal rotatory nystagmus, beating toward the healthy side, pathological head impulse test, and no signs or symptoms indicating a central lesion. What about the treatment? You have three treatment options: symptomatic treatment, causative treatment, and vestibular exercise. Symptomatic treatment. So you can give vestibular suppressants. Later, at the end of the day, I'll show you a new drug which has a tremendous effect on symptoms. If you give these vestibular suppressants, they're all sedatives. You should not give them longer than 3 days because they delay central compensation. We often give diamine-hydronate, and in severe cases you can also give benzodiazepine. Central compensation. There's good evidence from animal experiments that betahistine and acetyleucine improve central compensation. So you can give your patients for, let's say, 3 to 4 weeks betahistine in a high dosage. What about a causative treatment? Over the last 10 years, we did a lot of molecular biology work in the field of vestibular neuritis, and we mainly examined human vestibular ganglion cells. And we found that 60% of the examined human vestibular ganglion cells were latently infected with herpes simplex 1, and we also found the so-called latency-associated transcript in 70%. All this supports that it's caused by the reactivation of a herpes simplex virus 1 inflammation. Based on this idea, we had published 10 years ago, almost exactly 10 years ago, this paper in the New England Journal of Medicine. 4 treatment groups: placebo, steroids, virostatic, combination of both. Our hypothesis was that the combination is the most effective treatment. This, however, was not the case. A simple and cheap monotherapy with steroids is sufficient to significantly improve the recovery of function. And finally, vestibular exercises. We also published a controlled trial on that. We measured postural imbalance by posturography. There was a control group and a treatment group. Patient received vestibular exercises for 30 days, 30 minutes 3 times per day. In the treatment group, you see here that sway path values are significantly lower. So vestibular exercises are effective indeed in acute vestibular neuritis. Next patient. Please listen to her patient history.
You've come to us today because of dizziness. Could you again briefly describe for me what it's like?
Yes, it began last year in March. It was a very strong attack of dizziness, a rotatory vertigo, a turning from the right to the left, and with pronounced vomiting.
How long does the dizziness last?
It depends on the attack itself, often 5 hours, sometimes 7 hours, the strong attack of dizziness and vomiting. When it's over, my balance is disturbed for 1 to 2 days.
And how often do you have such attacks?
Currently, I have an attack once a week, every week at least one time.
Have the attacks increased recently?
Yes, last year when it began in March, I had an attack in March, then one in April, one in May, so each month an attack. Then there was nothing for 3 to 4 months. Then, since September, the attacks have occurred more often, once a week.
Did you notice any additional symptoms besides dizziness, symptoms coming from the ears, from the body?
When I experience dizziness, it is so strong that I can't really orient myself, because I can't balance, I can't walk or do anything. But since 1994, I have tinnitus.
In which ear?
In the left ear, and at such times I have a feeling of pressure or the feeling that the ear is stopped up.
So the diagnosis is very easy for you, Meniere's disease. And again, we have new diagnostic criteria, which are fortunately approved by the most international societies, Japan, Korea, the US, and Europe. And these are the currently recommended diagnostic criteria, which are going to be published soon. So at least 2 attacks of vertigo, which last 20 minutes to 12 hours. You have to document reduced hearing associated with one of the attacks, in particular in the low frequency range below 2000 Hertz. They have often fluctuating tinnitus and fluctuating fullness in the ear, and here again the standard sentence you're familiar with. So these are the current diagnostic criteria which are agreed on by all major societies. Nowadays we are able to visualize the pathophysiology of Meniere's disease. This technique was first described in animals already in 2006, and then it took a few years, more than expected, to apply that in humans. It's very simple. You inject gadolinium through the tympanon and run an MRI 24 hours later. So it's a very easy technology. And here you see a normal ear, here a cochlea, and these 3 images are from patients who suffered from Meniere's disease. And what are the black holes that you see? What do you think? This is the endolymphatic hydrox. Because gadolinium diffuses, for reasons we don't know, into the perilymphatic space and not the endolymphatic space. And if you have an enlargement of the endolymphatic space, you have less perilymphatic space, and thereby you can indirectly visualize endolymphatic hydrox. What about the treatment? Meniere's disease is known since 1861, and over these more than 150 years, a lot of treatments have been recommended. What we recommend is a high dosage treatment with betahistine. That was the first study on a higher dosage. It was just an observational study in 112 patients. One group received a low dosage, 16 to 24 milligrams TID. The other group received 48 milligrams TID. There was a significant effect of the higher dosage, and another finding was the longer you treat with a higher dosage, the higher the efficacy. And several patients, however, do not properly respond on 48 milligram TID. So some of the patients need 480 milligrams. This is a case series on 11 patients. And this is also our experience now. 48 TID is most often not enough. The majority of patients need evidently higher dosages. And now listen to this patient here, what he experienced.
Mr. Geis, you're known to have had Meniere's disease for about 1.5 years now. How many attacks did you have maximally per month before we began therapy?
Well, before beginning treatment, the worst was 18 attacks per month, sometimes less. Then they leveled off to between 8 and 10 attacks.
How long did they last approximately?
Between half an hour and 3 and 4 hours, and subsequently, I had problems keeping my balance.
Did then you began treatment with betahistine, first 6 tablets a day, each tablet 24 milligrams. How did you feel under that treatment?
Then the attacks remained the same, their frequency did not change, and how should I describe it? The attack intensity also remained the same.
Then over the last 12 months, we slowly increased the dosage and are now at a daily dosage of 40 tablets or 940 milligrams per day. How have you felt during this high dosage?
During the course of taking the high dosage, I had my last attack 5 months ago, and since that I had just a smaller attack with estimated intensity of 20%.
How do you tolerate this high dosage of 40 tablets a day?
In the meantime, it's not a problem at all. A first slight headache, but now I don't have any problems at all.
Thank you.
You're welcome.
So this is our recent experience that many patients need even significantly higher dosages. Now listen to this gentleman. What happened when he reduced the
You are
dosage?
suffering from bilateral Meniere's disease now for more than 8 years. It was very difficult to treat you, and we were very successful with the treatment with 20 tablets of betahistine, each containing 24 milligrams per day, for now more than 3 years. Then we tried to reduce the daily dosage from 20 to 18 tablets per day. We did that 3 times. What happened after we have tried to reduce the dosage?
After about 8 weeks, I have an attack with vertigo.
Okay. How do you tolerate the medication?
It's very good.
Thank you very much.
So in this patient, we 3 times tried to reduce the dosage, and always after 8 weeks, attacks reoccurred, and he's now free attacks for more than 3 years with 20 tablets. So then we were interested in a possible mode of action, and together with our ENT colleagues, we looked at the effect of betahistine on microcirculation in the cochlea. We used an established model. And prior studies had shown that cochlear blood flow increases, but the concentrations were much higher than the concentrations you would expect in humans. And therefore, we went down from a low dosage up to 1 milligram per kilogram body weight in the animal. And we used this animal model here, fluorescence angiography, and we ended up with this dose-response curve. And then we correlated the corresponding single dosages when administered orally. And interestingly, in the range in which we increased the dosage over the last 8 years, up to 160 milligrams as single dosages, there was a maximum increase of blood flow up to 1.35. This is just a correlation. It does not prove that that's the mode of action. And more recently, we looked at the different metabolites of betahistine, and there's one metabolite which is even more effective in an increase of cochlear blood flow up to 1.5, but this metabolite has only short half-life time. So to summarize this up, what we currently recommend is a dosage even above 144 milligrams per day. We have patients who take 50 to 60 tablets per day, 1,200 milligrams per day before they are free of attacks. We rarely have to apply gentamicin, which is effective, but has a lot of side effects. And not effective are endolymphatic sac operation, salt-free diet, and diuretics. So, what is this frog suffering from? Any ideas? This is the endolymphatic duct. BPPV. So this also occurs in animals, as David will later show. So this frog has BPPV. Here you see the otolith organs. This is the semicircular canal, and here's a clot of otoconia. And I like this video because it shows how slowly the clot is moving. Otoconia do not consist of plumbium or iron. As I said before, it's calcium carbonate, and they move very slowly. And you're all familiar with BPPV diagnosis and treatment. so therefore I just focus on the mechanism. And in most patients, it's caused by a canalolithiasis. That means freely moving clots within the semicircular canals. And they can explain all the characteristics. The symptoms normally begin with a latency. That's the time it takes to accelerate the otoconia. The duration is 30 to 60 seconds. That's the time it takes for the clot to move to the lowest point relative to gravity. Most patients have a crescendo-decrescendo time course with an equivalent nystagmus. This is due to the acceleration and deceleration of the otoconia. The direction corresponds to the canal. The fatigability is most likely caused by the movement of the otoconia out of the semicircular canal, and this mechanism of canalolithiasis also explains why liberatory maneuvers are successful. And for you, take-home message, when you do the diagnostic and the therapeutic maneuvers, give the otoconia enough time to move. 1 minute in each position. That's absolutely necessary. So, then the question arises, when you have successfully treated a patient, where do the otoconia go? Where do they come from? Any ideas? So theoretically, it's much more likely that they come from the utricle, which is here, than from the sexual. Where do they go? Same answer. We recently evaluated that important question by the O and the C band. We did a very simple experiment. 30 patients with BPPV treated with the Simon maneuvers. We had 20 responders and 10 non-responders. We measured the O and the C bands, and just to remember, the O band measured the function of the utricle. And this was here before the treatment, this was immediately after, and this was 1 week later. And 1 week later, we found a significant increase of the amplitude of the O bands in responders compared to non-responders. How can you explain that? Stimulation occurs with a mini shaker. And if you have now more material on the utricle, then the stimulation leads to a higher amplitude. And that's indirect proof that the otoconia do fall back to the utricle indeed. What about 4 weeks later? There's no difference. This is explained by a central compensation. And this correlates very well with the complaints of patients after liberatory maneuvers. They feel dizzy and unstable for 1 or 2 weeks. This is otolith dizziness. And in these patients, you can also apply beta-histine to accelerate central compensation. So this is an indication for beta-histine in the treatment of BPPV. It accelerates central compensation. The patients are not as long sick as they are without treatment. So now, the last patient, listen to the patient history.
What are your major complaints?
I have recurrent attacks of vertigo,
How long do they last?
2 until 4 minutes.
When did the symptoms begin?
In January this year,
How many attacks did you have over the last month, about?
I would suppose 500 attacks.
Were there additional symptoms before, during, or after the attacks?
Yes, I had pressure in the ears and tinnitus, and I heard too much. I had
Understand.
ear problems.
Okay. Then a few weeks ago we started with a treatment. How did the symptoms change after the treatment?
They become less, and since 2 weeks I have no attacks any longer.
Thank you very much.
So, what is the leading symptom in this patient? Recurrent short attacks of vertigo with some ear symptoms. What are your differential diagnoses? little bit louder. Vestibular paroxysmia or Meniere's disease. No. Migraine, vestibular migraine, conceivable. But what about this magical drug? Does that help to support the diagnosis? You give a drug and within 2 or 3 weeks, the patient goes down from 100 attacks per month to 0. What's the magic drug? Carbamazepine. And the diagnosis is vestibular paroxysmia. So, we published this case last year in Neurology because it was very special. Here you see the mechanism of vestibular paroxysmia. This is the MRI. You see here the 8th nerve, and there's a compression of the 8th nerve in the root entry zone. This MR angiography also shows this artery here from the ICA. And this patient responded very well to Tegretol but did not tolerate it, so we stopped it, attacks reoccurred, and he got surgery. And this is the intraoperative finding. You see here the vestibular nerve and the compression by the ICA. And then our neurosurgeon moved the arteries up and down, and this case was special because you can really see the compression of the nerve. And this patient now is free of attacks since September the 2nd, 2011, without any medication. So if you're sure about the diagnosis, surgery might be indicated. And again, we have a classification committee for vestibular paroxysmia. Nothing has changed tremendously. So at least 5 attacks of vertigo, which most often occur spontaneously, they last seconds to minutes. Rarely they can linger longer, up to 1 or 2 days. And as I said, they most often occur spontaneously, but they can be induced by certain head movements, and they can be associated with some ear symptoms. And this sentence I do not want to repeat. Mechanism is a neurovascular cross-compression, analogous to trigeminal neuralgia or facial hemispasm. And this compression normally occurs in an area of the nerve which is covered by oligodendrocytes. So strictly, anatomically speaking, the border between the peripheral and the central nervous system is this transition zone between oligodendrocytes here and Schwann cells. Schwann cells are evidently robust against compression, whereas oligodendrocytes less. So if there's compression here, then you got symptoms. And here you see this for the different cranial nerves, and for the 8 cranial nerves it's about 5 to 50 millimeters, and this is the critical area which leads to vestibular paroxysmia. We just finalized this placebo-controlled trial. The problem was we used oxcarbazepine. The dropout rate was 60%, so it's not a good trial, but this may happen. Anyway, despite a high dropout rate, we found a significant effect in the days without vertigo, placebo versus oxcarbazepine, but we plan another trial. So to summarize this up, recurrent short attacks of vertigo, then you should think of vestibular paroxysmia. Mechanism, neurovascular cross-compression. You should treat the patient with carbamazepine or oxcarbazepine, and thereby you can also make the diagnosis ex juventus. If the patient responds, the diagnosis is very likely. You don't need an MRI. If a patient does not respond, he or she may simply have panic attacks. That's another important differential diagnosis. So, we are approaching the end of this presentation. Just to summarize, DPPV caused by canalolithiasis, repositioning of the otoconia to the utricle. Meniere's disease, now we have accepted international criteria, high-dose treatment with beta-histine up to 1200 milligrams per day. Vestibular neuritis, herpes simplex, acute onset of severe vertigo, exclude vestibular pseudoneuritis, symptomatic treatment, steroids, rehabilitation. Bilateral vestibulopathy, movement-induced imbalance, no symptoms under static conditions, vestibular exercises. Vestibular paroxysmia, short attacks of vertigo, carbamazepine, perilimb fistula, pressure-induced attacks of vertigo. Now we can look into the future. We have currently 8 studies which are all funded by the Federal Ministry of Research on peripheral but also on central vestibular disorders. So there will be one trial on BPPV with vitamin D, one on vestibular paroxysmia with carbamazepine. This study is finished. One study on acute vestibular neuritis, again with betahistine on central compensation. Here we have recruited 80 of 240 patients. And central vestibular disorders, vestibular migraine, episodic ataxia, gait ataxia, and ataxia due to cerebellar disorders with either fampiridine or this modified amino acid. It's a Panganil in France, very popular. We demonstrated that it works very well in patients with cerebellar ataxia. So, thank you very much for your attention. I hope that I could give you an overview of the relevant vestibular disorders.